And our speakers for today are Dr. Chapman and Dr. Young. Dr. Norah Chapman has been an academic and practicing counseling psychologist since earning her PhD from the University of Kentucky in 2013. In 2013, Dr. Chapman joined the faculty in the School of Professional Psychology at Spalding University. She is an associate professor and associate chair in the School of Professional Psychology at Spalding University, directing the PsyD program in clinical psychology. Dr. Chapman co-founded the Rowan Specialty Clinic for Women with her friend and colleague to support psychological assessment and treatment interventions for women experiencing infertility, grief and loss related to pregnancy, and other perinatal mental health concerns. Dr. Chapman is also the co-chair and one of the founding executive board members for Postpartum Support International Kentucky chapter. Through both Rowan and PSI Kentucky, Dr. Chapman presents frequently on broad perinatal mental health concerns, vulnerable populations for prenatal and postnatal issues, and postpartum mental health complications. On a personal note, Dr. Chapman is a mother of a 2-year-old boy and a survivor of pregnancy loss, birth trauma with NICU experience, and postpartum concerns of her own. She is passionate about facilitating the healing process with women and families, navigating the unexpected blend of joys and challenges of parenthood. And I believe there's some other folks for me to let in, so let me do that. Okay, and then we'll continue with Dr. Young. So Dr. Young has been a practicing psychologist since 2011 after receiving her doctoral degree, or PsyD, from Carlow University in Pittsburgh, Pennsylvania. She obtained her master's in education from Duquesne University in 2002, and her undergraduate degree, BS, in psychology from Chestnut Hill College in Philadelphia, Pennsylvania in 1999. She received her Health Service Provider HSP licensure designation from the state of Kentucky in 2013 and her perinatal mental health certification in 2021. Dr. Young has been a full-time professor at Spalding University in Louisville, Kentucky since 2012. She currently holds the rank of associate professor and is tenured. Let me let one person in real quick. Okay. All right. All right, so she is a tenured. Dr. Young is also the director of clinical training at Spalding University, overseeing all of the clinical placements in the School of Professional Psychology for both the undergraduate and doctoral programs. Dr. Young currently serves as the co-chair of the Institution for Women's and Gender Studies at Spalding University. She helped to launch that organization, bringing together faculty focused on research into those issues from multiple disciplines across campus. Dr. Young co-founded the Rowan Specialty Clinic for Women, devoted to psychological treatment interventions for infertility stressors, grief and loss related to pregnancy, and perinatal mental health concerns. The Rowan Clinic provides both direct services to the community and potential training rotations for the doctoral students in the Spalding University program. Dr. Young is passionate about training the next generation of psychologists to have a greater familiarity with these concerns. Dr. Young is also the co-chair and one of the founding executive board members for the Kentucky State chapter of Postpartum Support International. She guided the Kentucky chapter to be chosen for the National Mind the Gap State Policy training series, which will be held in the fall of 2023. Dr. Young is a member of the American Society for Reproductive Medicine and participates in their ongoing training and consultation opportunities. Dr. Young presents frequently on broad perinatal mental health concerns, vulnerable populations for prenatal and postpartum issues, and postpartum mental health complications. Dr. Young is also the mother of twins and has personally experienced the challenges of miscarriages, high-risk births, NICU stays, and other unexpected events on the journey of motherhood. So thank you so much, Dr. Young and Chapman, and we're excited to hear what you all have to share.
Thank you so much, Brenda. We appreciate that wonderful introduction. Thank you all so much for spending your Friday afternoon with us and or lunch hour with us. We're excited to share with you some of the work that we do and just spread some education about perinatal mental health today. Our talk is titled, It Didn't Go as Planned, Understanding Challenges in the Perinatal Period. And we title it that way because most of the clients that we work with, plus also having our personal experiences, understand that while lots of times in society you see the hope of pregnancy, the hope of motherhood or parenthood, or the hope of, the journey towards that, doesn't really talk a lot about the challenges and the barriers and the unexpected experiences that people have. And so we do like to shed a little bit of light on that because that is a growing concern. There's more and more folks talking about it, and we hope to be both educated ourselves and share that with others who are in the mental health world here in the Commonwealth. So thank you again for sharing your time with us. We did just have a wonderful introduction, so we'll not reiterate. But the other thing that just is a little bit more late breaking is that Dr. Young and I are also the state policy fellows for Kentucky. So we do join in on learning about advocacy, helping to bring more advocacy and awareness to the legislation of Kentucky and making sure that we are working towards better policies as a state all the time. So there's lots of exciting developments there, but that is another place where we have a little bit of our ear to the ground. So we'll move on for time's sake, and I will pass the baton.
So we just included some terminology for you all. We know that there are folks in the room who may be doing this work. We have some of our fabulous graduate students here that have joined us, I see on the screen. And so we know folks have different kind of access points. So we just wanted to put up a quick slide about some of the terminology and verbiage and language that you may be hearing today. Know that these terms, some of them are more set in stone and some of them are always kind of in flux and up to interpretation. Postpartum being a good example of that, right? So I'll give you one quick example. We always talk about the postpartum period, and many people think about the immediate weeks and months following delivery. But we know that there are going to be postpartum complications a year after delivery, 2 years after delivery, and even recently, a lot of talk and languaging around really sometimes often seeing 5 years after delivery as when women are starting to report a reintegration or kind of finally feeling more secure and grounded in kind of their new roles and in that journey. And so these terms are always kind of changing and evolving, but we wanted to highlight some of those language terms for you today.
So one of the things that often others don't know also is that perinatal mood and anxiety disorders are the number one complication of childbirth. And so, as Amy just mentioned, sometimes women and families know this and while they're pregnant. Sometimes this happens as they're conceiving, if conceiving is a struggle, and then often postpartum. And so those numbers are deceiving because we know that sometimes women will experience delayed onset of perinatal mood and anxiety disorders. And as Amy mentioned, up to 5 years, people are experiencing different things. But often people don't realize that, I'm going to call it PMADs for short, so I don't keep saying that whole thing, but PMADs are the number one complication of childbirth. This is when we also are controlling for things like hemorrhage or preeclampsia issues, other medical concerns that often get a bit more airtime in the news and in the research. But one of the things that happens over and above, even when we're controlling for those concerns, are PMADs. So we're going to be going through a number of the different disorders with you. And some of these are well researched, others are maybe less well known. So some of them may sound familiar, but we'll also talk about some of the complications that, again, don't get as much airtime as some of the others in our world. But keep in mind that these typically are some of the most challenging things that women and families experience during pregnancy and after childbirth. You want to keep going? I can keep going. Yeah. So the first one we'll talk about is the one that probably does get the most airtime in the research and in the education, and it affects as many as 1 in 7 women. If women have NICU stays and families have NICU stays, and it doesn't matter the length of the NICU stay, it could be a couple of days, it could be a month or 2 months or longer. Rates of postpartum depression can go closer to about 40% in mothers with infants in the NICU, which is a stark number. And so we know that it's a pretty good likelihood that if a family has to spend any amount of time in the NICU, that there's going to be mental health challenges, especially if you think about, if you have to leave your newborn there and go home and do work and come back, and you're managing all of the physical complications of pregnancy and birth, and the logistical challenges that you're navigating. And so there can be a lot of mental health challenges after NICU stays. Um, a really scary statistic, actually, that I think it really deserves a lot of attention is that approximately half of women with postpartum depression go undiagnosed and untreated. We'll talk about screening later and the importance of that, but there's a lot of women that fly under the radar. We hear a lot and have experienced ourselves, right? That, you're not supposed to talk about not doing well after pregnancy. You're supposed to be joyful. You're supposed to enjoy all the newborn stage. You're supposed to enjoy the bliss of motherhood. And so that stigma and messaging from family members that may be certainly well-intentioned can leave women experiencing a lot of shame and a lot of silence with regards to their treatment or with regards to their symptoms. So a lot of people don't talk about the symptoms that they have. So about half of them don't get treatment or maybe go undiagnosed, which is scary because we know from the research that there's a lot of negative health outcomes both for mother and baby and undiagnosed postpartum depression in particular. So there's a lot of different things that you'll hear about in the research, but I'll talk about the most significant one being poor attachment on the mother's side. So moms sometimes with PPD talk about they'll say things like, I don't feel connected to my baby, or my baby deserves a different mother. They could do so much better than me. And so that leads to bonding issues, which, as we know, poor bonding can make it challenging for children and for that relationship. Certainly not forever, but can certainly delay some things for both mother and baby. The maternal risk of suicide is quite high. We'll talk about those statistics in just a moment. But again, one of the reasons why PMEDS is one of the #1 birth complications has to do with the risk of suicide. And this is especially true for women of color. We'll talk about those rates in just a moment. There's also infant and child outcomes with regards to mothers who have PPD. Sometimes infants can have poor sleep and may become underweight. Those are both symptoms in the literature that are that come out time and time again across the last decade. Those are pretty large themes. And then also the long-term emotional development of the child. So some studies of children with mothers who had PPD come out, and about 5 years old talk about behavioral issues or emotional concerns or anxiety. And that's not to shame anyone with PPD, right? The hope is not to do that, but the hope is to sort of raise awareness that the postpartum depression has a significant impact, not only on mom, but also on baby and the family as a whole. And these may be consistent characteristics that you expect with depression. And so there's a couple that we'd like to talk about specifically in the perinatal period. Typically when we think about depression, we think about sadness or sort of unexpected crying or feeling overwhelmed. And so a lot of our clients will say, what do you mean? I feel overwhelmed just because I'm a new mom. This is overwhelmed that typically exceeds a typical sort of newborn experience. Generally, what we see with postpartum depression is that overwhelm also then leads into negative self-talk or negative ideas about the mom. So moms will say things like, again, my baby could do so much better off with a different mom. I'm not a good mom. They feel guilty often. So again, some of that self-concept piece comes in here as well. I'll talk about the difference between baby blues in just a second, but irritability, agitation, and anger can sometimes come about with PPD as well. So while people tend to think about depression as sort of being withdrawn or having low mood, sometimes depression can present as irritability, agitation, and anger. And so just because you're seeing that may not necessarily mean that they have postpartum rage or other things. It could be a sign of depression. Sleep disturbance is another one of those things we sort of get side-eyed sometimes with our client because they say, what do you mean? I don't sleep. I have a newborn. Of course, right? But sleep disturbance tends to happen when a mom is able to have the opportunity for sleep. So let's say someone is watching the baby for a moment and they either can't sleep or they're sleeping so much it's very challenging to wake up, which again, there's always caveats in the newborn stage, but usually sleep disturbance even in the opportunity for sleep. Same with appetite changes and mood swings. So again, these are even when a mom has a chance to eat or a chance to grab a snack or something, maybe they don't want it, or they're eating more than is maybe typical for them, even prior to pregnancy. Mood swings, again, apathy and exhaustion are common in the perinatal period, of course. But again, this sort of gets into mom's not functioning, mom doesn't want to connect with baby, mom is having a lot of negative self-talk herself and really down on herself. Those are sort of the things that separate postpartum depression from baby blues. Baby blues also tends to remit after 2 to 4 weeks or so. Postpartum depression tends to last longer than the 4 weeks. So, most commonly we'll see that crop up between 6 and 8 weeks postpartum, and again in the perinatal period as well throughout pregnancy. So just to be aware that again, some of these things you'll hear mom say, but isn't this normal for me being postpartum? Maybe, and we can also do some assessment to dig a little bit further to see just how is the mom talking to herself? How, is she coping and is she able to function, within reason of what's being expected. So I'll finish this up and then I'll pass the baton in just a second. But again, this is a stark contrast to some of the things that are out there about maternal suicide. This is a stark number. Up to 20% of maternal deaths are due to suicide. And again, this is one of the reasons why PMADs are the number one complication of birth outcomes. And one of the reasons is due to maternal suicide. And again, like I said earlier, when we are controlling for hemorrhage, hypertensive issues, preeclampsia, a lot of the complications that you hear about medically, this is the thing that really drives those numbers up, unfortunately. And those rates tend to just skyrocket for women of color. So women who report other races tend to have 3 times the likelihood of having suicidal ideation in the postpartum period. Asian women in particular are 9 times more likely to report suicidal ideation than white women. And so again, hopefully this is something we're screening for anyway, but we especially want to do so in the perinatal period, just in case that is cropping up at any point in the perinatal period. We also don't want to forget about dads and partners because they often feel similar overwhelming stress as mothers. The research is pretty clear, especially in the last decade, these rates have sort of held true that 1 in 10 fathers become depressed or anxious after having a new baby join the family. Dads and parents, partners are often sort of forgotten about, right? We're focused on usually baby first, then we're focused on mom. And sometimes dads feel like, I'm the one that's got to hold everything together, or I need to, keep things moving forward. But we also want to make sure that we're assessing dads and partners for how they're doing emotionally as well. All right, I will pass the baton here.
So we talk about perinatal bipolar disorder. And again, we gave folks just a little bit of a framework to be able to kind of understand the ways that we're going to be screening and assessing. So later on, Norah talked about we're going to be talking more about screening, but really kind of watching again for those kind of elevations of mood. And again, it can be difficult to discern what is kind of normal postpartum transitions and mood shifts and elevation. And then where are there kind of indicators that something else may be evolving. And so we know bipolar disorders have altered presentations. Lows, we're thinking clinically as looking more like depression. The highs, we're always thinking about sort of mania or hypomania. And in the perinatal period, again, we're going to be looking for those mood changes, looking for those persistent elevations of mood that just seem out of place, things that are kind of going to maybe be on your radar as not sort of being consistent with presentations before labor and delivery. That decreased need for sleep is also a really good red flag. When we talk about screening and assessment and things to be aware of, we would anticipate that caregivers with a newborn are going to be having a high need for sleep. So when folks are reporting that decreased need or those decreased levels of sleep, that we're going to be asking some questions and wanting to do some good and thorough follow-up about could there be a bipolar presentation going on that's been triggered. And then, of course, the last piece is kind of thinking about that productivity. Are there kind of periods of above average productivity? And again, in the early stages of having a newborn, lots of energy, of course, around nesting and transition and all of the preparations and all of the tasks and things that need to be done. But when you're listening to clients talk about these periods of kind of sounding like they are overly productive or overly extended, then we want to be able to do some good follow-up and discernment.
Good.
Postpartum anxiety is another really important issue. You can see the stats. About 10 to 20% of perinatal women, we have sites in the literature and citations that even have a higher rate of that. So if you think about some studies reporting data and elevations of as high as 40% in the women who participated in those surveys, you can start to understand how prevalent the anxiety experiences can be. And we sort of look at a lot of risk factors. And again, this is a tricky thing, right? So Dr. Chapman was talking about that idea of discernment. How do we know the difference between the transitions that are going to be a part of the motherhood and birth experience, and then when things are becoming excessive or more problematic? And so, one of the things we have to tease out with postpartum anxiety is what are the normal things or the typical things, right? Normal in quotations, but the typical things that we would expect folks to be having worries and fears or thoughts, anxious thoughts around. And then when are those anxiety concerns or those feelings of worry and fear becoming more problematic and more harmful? And so one of the things we look at those patterns when we talk about risk factors. We think about the premorbid anxiety. Is this a client or individual that previously has struggled with anxiety throughout their lifespan development? We're, of course, going to be doing a lot of assessment and discernment around their family history for anxiety presentations. We're going to be checking on that thyroid imbalance, the hormonal changes and presentations. And there's also a lot of research about younger moms perhaps being more vulnerable to anxiety, not having the support systems, not having some of the other things that help us to be more resilient. And then the studies that kind of also talk about the links to education. And so there's a lot of data and literature talking about that highly educated women and caregivers may also have a period of having sort of more vulnerability to the development of postpartum anxiety. And that makes a lot of sense if you think about it, right? The more knowledge that you may have about some of the birth complications, pregnancy complications, access to lots of things can also sometimes make folks have those heightened patterns of anxiety. So sometimes awareness and having lots of knowledge is strength, and sometimes having lots of knowledge and awareness about all of the things that can go wrong can make people more vulnerable to some of those anxiety experiences. And of course, that last bullet point is really important. If you're working with a client that has a history of pregnancy loss, stillbirth experiences, or any type of medical complications, emergency procedures, we're going to talk about trauma here in a moment. Of course, that person is more likely to struggle with fears and worry and concerns that can start to present as more significant anxiety experiences. Once you've had things go wrong, you no longer have kind of the buffer or the protection. I talk about that with clients a lot, that like once you've been on the wrong side of the stats, once really bad things have happened to you in the world, you no longer have that kind of idealized protection. And so even when everything in later pregnancy seems to be going well, everything is healthy, everything is normative, you can understand how an individual would still have a lot of anxiety and worry because historically they've had losses and complications and things that didn't resolve in a positive way. So we try to just normalize that in our work with clients. We give people a lot of space to talk about how very natural that is, that if bad things have happened to you in the past, that you're going to be experiencing perhaps anxiety and a lot of fears and worries about your current pregnancy experience or pregnancy journey.
The next one we'll talk about is perinatal OCD. And so we hear you, and you may be familiar with obsessive compulsive disorder in general. So we'll talk a little bit about how that specifically looks for women in the perinatal period. So perinatal OCD affects about 3 to 5% of mothers and fathers. And in general, if you think about OCD, we know that it's characterized in a couple of ways. One, with intrusive thoughts, thoughts that come out of nowhere that are usually distressing, unwanted, tend to be sort of against somebody's value system and sort of feel like they want to be batted away. They're annoying and scary oftentimes to the mom. Most of the thoughts in the perinatal period with OCD have to do with harm related to the baby. And so clients will say sometimes they'll have intrusive thoughts about dropping their baby, or sometimes I've heard moms say, I'm so afraid I'm going to put my baby in the washer, or there's going to be something that, they have absolutely no intention of doing, no plans of doing, but they tend to have scary thoughts. And so you'll also see the other side, right, of OCD is the compulsive behaviors, particularly for women who've experienced loss. You'll see a lot of women do a lot of compulsive checking, maybe a lot of healthcare seeking to, check on baby's heart rate, check on baby's health, getting a Doppler to check baby's heart rate at home, all kinds of different compulsive types of behaviors, checking that baby is breathing at home, right? Which is, again, sort of get laughed at sometimes because what new parent typically doesn't sort of say, is my newborn breathing? Are they okay? But this is that plus more. And this tends to be something that takes up a lot of time. So they may spend a lot of time checking heartbeats, checking at the doctor's office for different things. So the amount of time that takes tends to show up more as sort of a full-blown OCD presentation. What we know though is that, even though these sound like very, these are concerning thoughts, are concerning behaviors, research suggests that, particularly with the intrusive thoughts, that moms tend to not act upon the thoughts. So even if they have a thought of, I'm afraid I'm going to drop my baby, most of the time that scares them so much that they often want to give the baby up to their partner to be able to carry them around, or that they get scared to carry a baby around. They'll only carry their baby or hold their baby when they're sitting down in a place where they just feel safe. So risk factors for OCD and perinatal OCD tend to be if they've already had some anxiety generally, or if they've had OCD prior to being pregnant, or if there's a family history. Sometimes the stress of pregnancy, the stress of the postpartum period tends to allow some of those genetic predispositions to come through. But a lot of times there's usually some type of anxiety prior. I do like to highlight this resource for you called Good Moms Have Scary Thoughts. It's a website that is up and running, but they also have a book just to kind of normalize for women that may be experiencing thoughts that scare them, that worry them, terrify them, that they are still good moms, and that there are, treatments and resources for that. But it often makes moms feel so ashamed that they're experiencing them that sometimes they don't come forward. So this is a great area to assess further if you're working with someone in the perinatal period, to just say, do you ever have thoughts that seem like they come out of nowhere that scare you, or, compulsively checking things that takes a lot of time out of your day? And just to ask those questions can at least help to screen for that going forward.
So, postpartum PTSD is a topic that not a lot of folks have an understanding around. Dr. Chapman and I have done a lot of talks to medical providers, nurses, OBs, all kinds of folks, doulas. And we talk a lot these days about kind of postpartum PTSD, just to be able to raise awareness and to talk about all the things that happen during the labor and delivery process, and all of the ways that that really can set clients up to have struggles. So we know that approximately 9% of women experience PTSD after birth. And so the idea in our culture is that labor and delivery is a natural thing, right? It's Mother Nature, it's what's expected. And so a lot of people just assume that this is a natural event. And so there couldn't possibly be long reaching complications, because this is something that, all kind of, birthing folks are going through, and that nothing can go wrong. But we know that there's a lot of real and perceived trauma that occurs during the delivery process that really has a lasting impact on kind of the mental health and the well-being of folks who experience some of those issues. So on the slide, you can see we gave you a bunch of examples of just things to, again, be assessing for as you're screening, as you're working with folks in this population, to kind of ask them about their birthing experience, about some of the things that may not have been expected, and to, again, give them kind of time and space to be able to talk about their delivery process. One of the things that we've learned from the medical folks that we've kind of been involved in work groups with and done trainings for is that there's often not a lot of time for communication. So if you think about what happens when there are emergency procedures happening during delivery, right? The number one priority, of course, is the life and safety of mom and the baby. And so the medical staff are often very busy and consumed with attention and focus on all of these procedures and things that need to be handled properly. What there's often not a lot of time for is explaining to mom what's about to happen to her, different injections, different procedures, right? There's not a lot of time for communication. There's very little time often to ask questions, or to even sometimes be able to make decisions. Sometimes it is the other birthing partner who's going to make life and death decisions about mom and baby and their health, their body autonomy, decisions around what the labor is going to unfold, how that process is going to evolve. And so what it does is it sets people up for feeling incredibly scared and overwhelmed by all of those circumstances. And even when the medical staff know that things are resolving, even when medical staff know that some of the things that are happening may be a part of their normative response, right? So that's why we have on there kind of perceived trauma, because even when there are events happening that perhaps are not always life and death in the circumstances, we still see individuals experiencing and struggling with PTSD symptoms afterwards. Because in that moment, the mom who's delivering doesn't know what's always happening, and they may not know what is life threatening and what is not, what are normal interventions, IVs, right? Like, what are the normal procedures of labor and delivery, and what are things that might be more signs of more dangerous or more serious complications. And so whether or not the trauma is real or perceived, you can imagine how all of these different events, all of these different medical procedures leave folks feeling incredibly scared and overwhelmed. And so we work with a lot of clients who really have a lot of sadness about their delivery experience. Things did not go according to plan. They had a vision in their mind about what their labor was going to be like. And it's usually like a very lovely story about how they were going to feel and those moments and holding the baby. And they've kind of conceived this very lovely, idealized version of what their delivery was going to be like. And then instead, they've had an experience that might have been very traumatic, very dangerous, very life threatening, not the lovely, glowing, tender moments with their newborn, but something that was much more frightening, much more intense, much more scary. And so they really feel robbed of that, that they didn't have the labor that they had imagined. They didn't have those precious moments afterwards. They didn't have a joyful delivery, that their labor and delivery was much more scary and unexpected. And so that creates those symptoms and feelings about being powerless, feeling unsupported, not feeling like medical staff communicated well, not feeling like they were included a lot of times in some of those decisions. And so that leads to this ongoing pattern of kind of a lot of sadness about how their delivery process unfolded. And then the last bullet point, we talk about the near miss experiences and how there really isn't good data around that. It's one of the things we've talked about. There is the morbidity and mortality data. I actually sit on the task force for Kentucky, the folks that kind of gather to look at some of the data and stats about what happens when there is maternal death. We have kind of the stats and information about many of those experiences. What Kentucky does not track effectively or gather data around are all of the near misses, all of the women who almost died during delivery and what happened to them and was there follow-up, were they given any kind of resources to help them in their aftercare experiences. That's a data set that's really missing, and so those are often the folks that we have contact with as we are kind of out and about doing this work, talking to survivors who feel like no one really explained to them what happened and no one really gave them thoughtful support and care afterwards. So that's where we come in. This is the pattern of how PTSD is created. So for all of the psych folks on the screen, you know that, right? But really thinking about the perinatal experience and frame is understanding those shattered expectations and how some of those folks have waited their whole lifetime imagining what it was going to be like to give birth and become a mom, and how all of those images and expectations weren't fulfilled in the way that they imagined. We see a lot of clients who are re-experiencing the trauma, have a lot of folks that talk about like even their aftercare appointments, just going back to the hospital, getting off the elevator, going back into some of those settings, the smells, the sounds, really is very triggering. It's very difficult for them to be in a lot of those environments afterwards. We've even had clients that will kind of talk about that. It was hard for them to even go to aftercare appointments, to do some follow-up things that they needed to do for their own health and wellness, because just the thought of going back into some of those environments was incredibly scary and overwhelming. And then, of course, the hypervigilance. Once trauma has happened to you, we again see lasting presentations where folks are going to have those heightened periods of anxiety and those hypervigilant responses where they're going to be more alert, more on guard, and doing a lot of things that make sense when you think about the trauma and some of the things that they were recently immersed in.
So the last one that we'll talk about is postpartum psychosis. And unfortunately, there's a lot of airtime that this gets when something horrible happens, whether it's a mom or a baby, and something terrible happens with them. But we'll say postpartum psychosis, the prevalence is low. However, when it happens, can have very serious consequences and outcomes. And so the prevalence rate is about 1 out of 500 women. I think the quote is one out of I believe it's two every 1,000 births, I believe. So it's relatively rare. However, when it does happen, one of the first things that people will notice is just odd behavior, whether that be, maybe mom isn't sleeping when she has the opportunity to. That tends to be one of the predicting factors of a major mood shift, is just, again, sleep disturbance creates a lot of vulnerabilities for a lot of things. But if somebody particularly has some premorbid bipolar disorder, maybe has had psychotic experiences in the past, all of those things can create much more of a vulnerability for developing psychosis in the perinatal period. But what you're going to see is that there may be some behavior that just indicates kind of a complete break from reality. So mom might be having some scary thoughts, seeing scary things that other people don't see, hear, or believe, and they may not be true for others. And so you'll see extreme mood shifts, a lot of irritability, a lot of withdrawal, mostly because of the fear of the thoughts that they're having, and a fear and maybe some paranoia about people around them. Sometimes we'll hear about there's a lot of paranoia about their partner or other family members who are helping. And so you'll see them sort of maybe isolate with the baby to try to protect them from people that they believe have some interesting beliefs about. And so if anybody recognizes that in a client, or if a family member comes to you, this is considered a medical emergency to be able to get immediate help and treatment. So going to the ER, reaching out, I'll talk about the psychiatric line here later on, but reaching out for support ASAP. And again, oftentimes partners and family members are the ones who first see postpartum psychosis. They may start to notice odd behaviors, odd thinking, odd beliefs that come about that are different than what they are understanding of their partner. So just know that this is an emergency experience, and a person's not going to be able to agree to logic. They may not be in a place where they're able to make a rational decision for themselves. And so you or a family member is going to need to be the one to sort of help initiate treatment and get them help. And we'll talk about, again, some of those places where you can call and where you can get some immediate support there.
This is our brief kind of slide about grief and loss. We actually have like a whole separate training that Dr. Chapman and I do around grief and loss, because this is one of our personal, like really thoughtful spots when we're kind of doing training and workshops and education, just trying to help people have spaces and places to be able to unpack their grief. This is one of the areas that I think people often get messaging around. So, we've talked about all the different ways that folks feel uncomfortable to share their struggles, whether it's depression, anxiety, their trauma, psychosis. Very often people talk about, I got the message very clearly that I needed to pretend like everything was fine, that I was ashamed to admit the struggles and the feelings and the problems I was having, that I just very quickly learned that other people around me and society in general was not open to listening to me talk about the struggles that were happening to me in my kind of journey around motherhood. And grief and loss is a really good example of that, where folks really talk in language about how difficult it is to be able to find ways and places to be able to really unpack that grief. So we know that when we look at the stats, right, we always give you good stats and data just to give you a sampling of, the prevalency of occurrence. We know that about 1 in 4 pregnancies end in miscarriage. And many people feel like that number is, of course, underreported data, because many people are not aware that they're pregnant, or they don't kind of language that. people are often very sort of hesitant to talk about their loss experiences. But if you think about that number, 1 in 4, that's a staggering data set to think about how often then people around you are kind of navigating and sitting with those grief experiences and that struggle of loss. So, we talk about miscarriage being defined by pregnancy loss before 20 weeks, and then stillbirths are kind of the language and the verbiage that we use for loss after 20 weeks of pregnancy. And that's kind of the medical terminology. That's the professional lingo. What we know that is with real people and real families that are grieving, it doesn't matter when the loss occurs, the impact is going to be the same, right? So, kind of realizing that it doesn't matter if the person was a few days into their pregnancy or they were at 40 weeks, right? It's going to have the same sadness, the same emotional weight, the same sort of pain and loss experiences. So, those time markers are just kind of to give you a sense of the medical language, not to say that one is more valid or one is worse or one is more important than the other, right? Because all grief is incredibly destabilizing and really changes people in a way that is permanent and that is lasting. So we try to talk with folks about kind of understanding the full experience of grief, that grief is not something that is curable. Grief is not something that you like move away from. Grief is really about sort of integration. And so talking a lot with clients about integrating loss, having spaces to talk about what happened, to tell the story of their loss without sort of being shamed or shut down. And then also moving into restoration, finding meaning in the loss. The literature really speaks to that, that the thing that is the most perhaps healing, whatever that means, right? We don't have like judgy language with that. Healing is sort of whatever people need it to be, but that finding some type of meaning or purpose in the loss is often very helpful and can make people feel incredibly empowered or supported in their grief to try to find some type of meaning in the experiences that have happened to them. And so we just kind of try to give people spaces to be able to do that. We also do a lot of role playing. I talk about that a lot with the students that are in the Rowan Clinic with us, that one of our jobs, I think, is to help get people ready to deal with the unhelpful sort of language that they may receive from folks around them. So we also spend a lot of time with clients helping them learn what to say. So when people say very unhelpful things like, well, there must have been a purpose for that, or better that it happened now rather than later, better that you had a miscarriage rather than losing the baby after delivery, things like that. People say terrible, awful, insensitive things to folks that have had loss. And so we spend a little bit of time doing a little bit of behavioral rehearsal almost and helping people learn what to say when people speak to you in that way, how to handle those situations, how to learn to be able to give voice to the story of your loss, and how to kind of answer the messages that society often gives folks about how they should be feeling about their grief. So we spend a lot of time trying to be supportive around some of those issues and helping people be able to transition and just be able to talk about their story, to be able to tell that narrative in a way that is meaningful and valuable to them. So, like I said, we have a whole separate training that we love to do for folks. So, if you have questions or want to talk more about that, Dr. Chapman and I are also about to start a new grief and loss group, and we can talk more about that. So, if you've got folks that you think would benefit from some of those services, we are always happy to do more training and education around all the nuances that connect to grief and loss work.
And grief and loss often also shows up in the infertility aspect and conception of trying to have a family, right? So a lot of people that we work with maybe are looking to start a family and it's not going as expected, and it may take longer than they thought. Sometimes families are also needed to have medical support, right? And so we know that about 1 in 8 couples have trouble getting pregnant or sustaining a pregnancy for various reasons. And there's some clinical definitions of infertility being the failure to establish a clinical pregnancy after 12 months of regular, trying and working through on their own. But sometimes that's not possible, and we hear a lot of grief and loss, even in that women are really they had this idea that, oh, I'll just get pregnant in a couple months. It won't take very long. And then the longer it takes, the more sort of shame they start to experience or start to wonder, what is it about me or us mostly it's mom saying, "What's wrong with me?" And so there's a lot of sadness, grief, and shame in the process of trying to even get pregnant sometimes if that does not go as planned. So one of the pieces of education that we try to give moms and families and couples going through this is that about a third of infertility originates from the female partner, one from a male partner, and then a third is a combination of both. And so sometimes when we're working with women, they'll come in with lots of shame and lots of, what's wrong with me types of questions. And so providing this education sometimes says, this isn't just you or just your partner. It could, there's sometimes unexplainable reasons. And sometimes it's about grieving that there's not this known thing that they can point to say this is why. And so there's a lot of work to be done in that area as well. Um, and I think that again, thinking about what is sort of the typical message that you hear in starting a family, you think about, oh, it'll just take a few months, or, oh, we won't have any issue. But we know that couples 29 to 33 who otherwise are healthy, otherwise have, no other medical issues, have 20 to 25% chance of conceiving at any given month. And that's surprising to people. You get a lot of education and, middle school, and it's happening earlier these days, but middle school, high school about preventing pregnancy. And so I think that creates this idea that, oh, it's so easy to get pregnant. And so when people begin thinking about having a family, they don't factor in, really the chances actually are kind of low, each month, especially for couples in that age range. And we know that as couples age, that percentage goes down as well. And so some of this education is really helpful to give couples at the outset of conceiving and to let them know that, the idea in your head or the story that you might be thinking about may or may not happen, and to just leave some space for the unknown. So there isn't this shame of, oh, there's something wrong with me, that it didn't happen the way I thought it would, or the way that I thought, the way that we were planning for it to happen. Sometimes there's medical concerns that get in the way. Infertility is a medical diagnosis. And so when people talk about infertility, there is a definition to that, and it is a medical concern. It's not just there's something wrong with that person, for who they are, or a deficit in that person for who they are. It is a medical complication. Do you want me to keep going with this one?
Yeah,
Take this
go
one?
ahead. You do this.
Okay. This is my favorite, so she knows that this is my soapbox issue. So we've talked a lot about different presentations of mood and anxiety disorders in the perinatal period. And so how do we know? When we first started, we talked about a lot of women go untreated and undiagnosed, 50% of them. And one of the reasons why is that sometimes we know universal screening doesn't always happen, and it doesn't often happen in any sort of consistent format. And sometimes if and when it does, that nothing gets done with it. We hear that often from women, that they might go to their OB or might go to a pediatrician appointment. Sometimes people are screened there, and then they don't hear anything about it. And that was my experience. I would get a form, I would get an Edinburgh every single time, and I would give it to the nurse, and then nothing ever happened with it. Never saw it, heard about it ever again. And we hear that more and more from the women that we work with. And so it's incredibly important that we think about how to screen, at what intervals to screen, and who does the screening, and then what is done with it. So Postpartum Support International does have recommendations for a screening frequency. Most all of the different organizations, like the American College of Obstetrics and Gynecology, have sort of a frequency that's recommended. Other folks do as well. The AMA has recommendations. But we tend to share Postpartum Support International's recommendations, one, because I think it's the most thorough, and it sort of allows for more opportunity to catch early signs of PMAD. So PSI talks about screening in the very first prenatal visit. So the very first time that there's a verification of pregnancy, they're being screened. This also gives the opportunity, if there is a loss at that time, that we can catch that, and that we can make some referrals from that visit. As the pregnancy continues, PSI recommends screening once in the second trimester and once in the third. So much can happen in every trimester, and especially if women are already experiencing depression, anxiety, OCD, trauma, those kind of things, those visits tend to be really vulnerable times for women, where more anxiety or more sort of worry crops up, or especially if there's pregnancy after loss, more and more of those types of symptoms will crop up at various times in the pregnancy. So to be able to catch that throughout the pregnancy, I think is really critical. They also recommend 6-week postpartum OB visits, or sometimes it's sort of embedded in the process to have a first postpartum visit. I think that's fairly universal. I'll, put an asterisk on that just in case that's not accurate. But a lot of times there is a recommendation for that. Now, whether or not folks follow through, that's different. But it's recommended that, as soon as possible. I personally think 6 weeks is a long time. Nobody's asked me, but I think 6 weeks is kind of a long time for that to wait. But that is one of the recommendations. And then repeat screening at 6 and 12 months in OB and primary care settings, or at 3, 9, and 12 months pediatric visits. So again, this PSIs is the most thorough and most frequent recommendations for screening. So if you are working with somebody in the perinatal period, ask them if they're being screened, or try to do your own screening if they are working with you. And we'll talk about some screening options here in Kentucky. But we'll talk about why that matters as a state. I know this is Amy's soapbox, so I'll let her talk about this one. But yeah, there's reasons why that screening is so important, and reasons why we have a lot of work to do in our state on this.
Yeah, so just quickly, you can look at our report card, and know that there are lots of good folks looking to improve these outcomes, right? So that's the good news. So when you look at all the ways that we are not kind of living up to the anticipated standards or the expected standards, you can kind of see all those areas that they've been able to identify. We don't have a lot of inpatient programming. We don't have a lot of providers. We don't have enough folks that have been trained. The PMHC is kind of the national certification around some of these issues. We don't have enough providers in the Commonwealth that have gone through those trainings and have passed their board exams and have that certification. So you can see all the ways that we need to improve. The good news is, though, is that we have several task force that are underway. We have a lot of really talented and passionate people and providers, legislators, folks in the medical community that are really working hard. There's amazing things that have happened over the last few years, really looking to improve the outcome data for Kentucky, and really looking to improve a lot of these areas that have been indicated. So hopefully in the next 5 years, we're going to be talking about a lot better outcomes and how we're continuing to move forward in a stronger direction.
Absolutely. When I was looking at this, there's only actually about 2 or 3 states that have a better than a C. So just nationally, this is something that lots of states are working on, and there's lots of wonderful initiatives being done. So we hope that you'll join in on that work. So just a couple of things to think about, especially if you're working with women who are either looking to conceive, or trying to conceive, or in the perinatal period, is to think about some risk factors for developing perinatal mood and anxiety disorders. So for women who say, just in general, it's hard for me to ask for help, that might be a great treatment goal to be thinking about, because, especially for women who want to do it all themselves, not ask for help, maybe don't have a lot of people to ask for help. That could be a logistical support question. But to sort of do role plays, or do some interpersonal education and treatment around that. If women have had trouble with hormones, or experienced previous depression or anxiety, either prior to pregnancy, during the last pregnancy they had, or last baby that they've had, they are at increased risk for developing PMADs after their most recent baby too. There's a genetic predisposition to mood disorders. Maybe a mother, sister, aunt, somebody biologically in their family has experienced postpartum issues. That person is also then at increased risk for developing something of their own. A huge red flag for folks who are working with women in the perinatal period is that if they are experiencing times where it's hard to slow down, or if they don't need sleep, if they have lots of new ideas, or they're getting a lot of things done in a very short period of time, or feel restless or unusually irritable, you definitely want to screen for some of the more concerning conditions like perinatal bipolar disorders and psychosis. A lot of women who develop PMADs also say, I don't have a lot of family and friends nearby, don't have a lot of money for food and housing. And so again, these are sort of general screening things that we want to encourage folks to ask about, or to just kind of keep an ear listening out for as well. So those are more general, semi-structured interview questions. We also have several screenings that are more evaluated and out there. So I'll just talk about this one real quick, and then I'll have Amy move on. But you'll typically hear two or three different types of screeners that are routinely used. We have the PHQ system, so it could be the PHQ 2, 4, or 9. One of the things that we encourage is asking is really trying to, if you can, use the 9 because it does talk a little bit more about anxiety symptoms also. The PHQ and 2 and 4 tend to focus mostly on risk and depression symptoms. And so if you can use the 9, it does give you a bit more information on that. The GAD-7 or the generalized anxiety disorder screener offers a bit more about general anxiety. Most of this is associated with worry, so it may miss out on some of the things like trauma and other types of anxieties that women may experience. Kind of the current gold standard to use is the Edinburgh Pregnancy or Postnatal Depression Scale, the EPDS, that has been just recently retooled with some new language. It is a 10-item screening measure that does also include a risk item about suicide. So again, the PHQ-9, the EPDS both incorporate this type of an item so we can screen for suicidal ideation among moms. And so I know we have just a couple minutes left, so we'll just kind of roll through these. I just sort of described a lot of this to you briefly. Do you want to talk about the pass, Amy? Want me to talk about it?
Yeah, go ahead, and then we'll talk about
Yeah.
our screener.
Yeah, I'll let you do that one. So we have the pass. This is one that is maybe not as well known about, the perinatal anxiety screening scale. It is a little bit longer. It's 31 items. One of the reasons I really like it though is because it goes beyond just worry, which I know is not just, it's concerning in and of itself, but lots of other symptoms that moms will talk about in the perinatal period are important to catch and to be able to monitor. And so this will allow you to do that if you are able to use this in the setting that you're in. So there's some information about this. It is readily available, just like the PHQ, the GAD, and the Edinburgh. So it's free to download and use. Again, know that it is a little bit longer, but for me, at least, if we can kind of catch some of those things, like repetitive thoughts that are hard, like the OCD sort of presentations, to me, it's worth it to be able to cast a little bit wider of a net, but not as wide as, and I'll alley oop to Amy.
Yes, so this is the part of the self-promotion, the shameless self-promotion part of the, the workshop today. So our research interest group inside the Rowan Clinic, we've been working on our own screener, and there are some folks on the screen. Some of our students, again, are here who have been a part of that process as well and done amazing work helping to work on the screener. So what we're attempting to do, we're just beginning kind of testing and pilot testing. And so if you have if you're willing to kind of help us in some of that screener dissemination, we're getting ready to kind of start to gather some good data about the things that we've been up to. But basically, we're looking at the Rowan Maternal Mental Health Screener, right? The RMOMS is basically going to be a 22 item of self-reported measures where we're hoping to incorporate a lot of the presentations and symptoms that we've been talking about today. So having an integrated tool, one tool to be able to address all of those concerns. So when we think about practicalities, when we think about efficiency in other types of settings, medical settings, nonprofit settings, lots of other places where we'd be able to reach moms and families, we thought if we can create a screener, a one tool item to be able to flag some of the symptoms that we've been talking to you all about today, what a wonderful point of screening and advocacy that would be. So if you're interested in supporting that research, please reach out to us. We would love to send you our link.
Yes, yes. Very exciting. So just really quickly, the good news that, that we'll end on is that PMADs are treatable. We do need to screen for them, be aware of them, be able to do some good assessment to be able to understand what they are and to be able to recognize them, especially if the women that we're working with or families that we're working with are not recognizing them in and of themselves. So cannot say enough about Postpartum Support International's resources and offerings. They offer weekly online support groups that are virtual. They are led by trained facilitators all across the country. Lots of different groups are offered. Some are offered in Spanish. There are military mom groups, BIPOC mom groups. There are lots of different offerings. And there's lots of sort of subsets as well. So if you're working with somebody who maybe has had a pregnancy complication or a child was diagnosed with a genetic concern, things of that nature, they're really specific. And so I give this information just about to all the clients that I work with. They're fantastic. There's also a helpline that's here. Now, this is not a crisis line, but this is a warm line. So if someone's looking for resources, looking for providers, you can utilize this information to get to them. There is also a National Maternal Mental Health Hotline, the TLC Mama number, which is, I believe, a crisis line. The PSI number is not, but the Maternal Mental Health Hotline is. So just want to make sure that that is differentiated when you're sharing that with folks as well. We also have, again, our shameless plug, we'll just go ahead with it, is the Rowan Specialty Clinic for Women in the Center for Behavioral Health. We have a fabulous student this year who's on the screen. We've had fabulous students in the past who are also on the screen serving in this way. And then Amy and I also see clients through the Rowan Clinic. The nice thing about this is that especially if they see the student, the sliding scale fee is quite low. We don't take insurance, but we will work with people on a payment that works for them. And they don't need a referral. They can just call or email us. And we're happy to share more information with you if you're interested in that. PSI, I'll go back to PSI's information also. If you look at Postpartum Support International's website, you can also search for providers in their directory and sort of see who's trained in this area, who's a good referral for this particular client or for this family. So there's lots of options, thankfully here in Louisville, and somewhat in those surrounding areas as well. And we're working on beefing that up through PSI to make sure that we're able to extend the number of folks trained in perinatal mental health work. So I can't believe we made it in an hour. That's impressive. I'm very impressed with us right now. We usually can go on and on, but I'm glad we could do that in an hour. Thank you all so much for having us, and we hope that this is informative for you. If we can answer questions, we're happy to. If you want to email us, more than happy to talk further with you.
Thank you all. It was a pleasure.
All right. Thank you so much, everyone. I think we can cap it there. And yeah, hope that everyone has a good rest of their Friday. Thank you so much, Doctors Chapman and Young. Yeah.
Thank you so much for having us.
Thank you. We enjoyed
Bye,
it.
everyone.
Take good care. Bye, everyone. Thank you.